Welcome to Nurse Practitioner Week. The presenter for this session is April Dobroth, DNP and FNP. Dr. Dobroth serves as a regional clinical faculty member for Frontier Nursing University. For over 6 years, she has served in rural and underserved communities as a National Health Service Corps provider and has been appointed as an ambassador for the National Health Service Corps in the state of New Mexico. Additionally, she served as a representative for primary care providers on the New Mexico Behavioral Health Coalition, where she worked closely with the Director of Health and Human Services, the Governor, Suzanne Martinez, and several other medical professionals in New Mexico to address the dire need for increased access to behavioral health services in the state.
Hello, everyone, and thank you so much for joining me for this presentation. Today, I would like to talk a little bit about the integration of mental health services into primary care. My name is Dr. April Dobroth, and I recently graduated from Frontier Nursing University. The presentation that you will be seeing today is based upon my doctoral DNP project research. So I hope you enjoy it, and I look forward to hearing from you in the future. So we know that mental health is in a dire need, and we've really reached a crisis point in the United States. Sadly, this has been most highlighted by recent events in the news, in particular the mass shooting that occurred in Las Vegas. There's a great deal of legislative focus upon the provision of mental health services. There's a public outcry. Some of the things that we do know that have really come to light from some of these tragedies over the past few years is that we know that there are 7.5 mass shootings per week in the United States. About 58 Americans die each day by gun violence. The majority of this violence is related to gun-related suicide. So it's a terrible problem, and it's something that we certainly need to address. What we do know is that most suicide attempters spend less than 10 minutes deliberating before they make that suicide attempt. So there's a very short period of time, a crisis period, in which these folks think about what they're going to do or plan their actions. About 45% of patients dying by suicide, it has been found, were seen by their primary care provider in the month preceding their death. This is really crucial when we think about integrating these mental health services into primary care, because when we think about people in crisis, particularly mental health crisis, it's very difficult for them to seek that care through the emergency room. And as we'll find out later in the presentation, it's also a very costly affair. So it's difficult to get the care through the ER, and it's also extraordinarily expensive. Another fact to keep in mind is that only about 20% of patients that did die by suicide were seen by a mental health professional in the 3 months previous to their death. So really capturing those folks in the primary care milieu is what we really need to be focusing on. Just to give you a little bit of an introduction, this project was focused in a predominantly rural area of southwestern Colorado. It involved the creation of an integrated model of care. This integrated model of care had several provisions that were interwoven, and you'll see in an illustration later in the presentation. We were able to provide on-site mental health care. So if someone called into the crisis line, there was a crisis line that was basically manned, womaned by mental health providers, such as social workers, licensed practical counselors, LPCs, and these folks would answer the phone and receive those initial crisis calls. That patient that called a mental health crisis would then be filtered through the mental health service provider within 24 hours. They would be seen within the primary care clinic within 48 hours, and then they were seen by a psychiatric mental health nurse practitioner within 1 month. Now, this is crucial because there was a great deal of communication between all of these providers, and what that allowed for is the prompt treatment of this patient in crisis. It also allowed myself as the key primary care provider to really work closely with that psychiatric mental health nurse practitioner to provide medications and that first line intervention for those patients. If they were needing something to help them to sleep, refills of their current behavioral health medications, whatever the case may be. It allowed us to intervene quickly and work very closely together to really meet the needs of the patient. One thing that was particularly unique about this area is you had a real lack of access to care. One, because it was rural. Two, there was a real financial barrier to care. In this particular area of Colorado, you had a very high cost of living and a predominantly high rate of poverty. So the high cost of living coupled with that high rate of poverty made it extremely difficult for people to get that care quickly. So the real purpose of this project was really to examine this integrated model of care and really meeting the needs of patients in crisis and patients across the board. This was rolled out in a small town city of Cortez, Colorado, within southwest Colorado. The model of care was examined according to the IHI, or Institute for Healthcare Improvement's triple aim. So it really focused on improving patient reported quality of care. It also focused upon improved care to the entire community. So really taking that 30,000-foot view and looking not only at the individual patient, but also the community at large, and also decreasing the cost of care as well. So we have several interventions. And I mentioned just very briefly in this model of care that was implemented at the Access Health Clinic in Cortez, Colorado, that we had several specific aims. One, we had a primary team lead, which was myself. We also had a mental health team lead that could be a social worker in this case, or a licensed practical counselor could also serve this role as well. There were counseling support staff, so this really enabled people that were in crisis to be seen very quickly. The crisis team was made up essentially of the mental health care providers, and they would take turns answering these crisis calls. So it was like carrying a beeper, if you will, or a cell phone and being on call during those hours. This is a visual illustration of how the model of care essentially worked. So we're really focusing upon that integrated home model of care for the patient, where they're really receiving all of their needs are being met through that home model of care. So the patient, family, they enter through this milieu of care. They're seen by their primary care team lead. So that would be your primary care provider, who works very closely with that mental health team leader, who may then also work with behavioral health technicians. These can be, say, someone who's very familiar with the particular community. So in Indian Health Service, this might be represented as a tribal outreach person. In a particular community, it might be someone that's real familiar with the culture, the language, and needs of that particular community. This mental health team lead could also reach out to both pediatric and adult psychiatry. Also, there would be an outreach milieu for chemical dependency treatment, and someone that really helps to bring this all together in an evidence-based practice. So we're really talking about an entire team approach with an ongoing patient support system. One of the things that I really want to highlight in this model of care is that it's very malleable. So depending on the needs of the particular clinic, the community, and what the particular clinic or community may have access to. It's extremely rare to be able to have access to a child psychiatrist, for example. So that adult and/or child psychiatry might take the form of telepsychiatry. It might involve something like the Project Echo Addictions and Psychiatry program, which is completely free and accessible to all healthcare providers. Patients can be integrated through that Project Echo system anonymously, and primary healthcare providers can receive really valuable feedback from an entire team within Project Echo of, say, 8 to 10 psychiatric and addiction specialists. So that's one way to go about doing this if that isn't available directly within the clinic per se. And the same would hold true for that chemical dependence. However, a caveat to that would be a need for outreach in particularly acute situations. Say if someone's going through alcohol withdrawal, you would need to have a working relationship with a local hospital to help get those folks treated safely through the withdrawal process. Another component that's very important to this model of care is your administrative support. So when that patient's checking in, when that patient's checking out, they're receiving, say, a quality improvement questionnaire, and I'll talk a little bit about the tool that we utilized during this project. Ideally, you would have a financial resource counselor. This could be within the clinic. It could also be within the community. So it's about really building those strong relationships to provide these key components. So that if you have someone, say, that's suffering from severe depression, but they're also facing a great deal of economic barriers, it would be the ability to really connect either in the community or the clinic with someone that could help that patient resource, say things like Medicaid, food stamps, crisis intervention, those types of things. And community resources comes into play. Let's say you have a patient that's experiencing domestic violence. It's really about being able to reach out to those community resources to get this patient taken care of, as well as their family members. So our primary aim was to create this model of care that fully integrated mental health services into that primary care setting while really addressing those patients in crisis. This was focused upon the Institute for Healthcare Improvement's triple aim to increase patient satisfaction, improve that overall health of the community, and to decrease that per capita healthcare cost in treatments. So our analysis was broken apart into 3 different parts. We were able to look at patient satisfaction using the Collaborate tool, which is very important because the Collaborate tool was chosen in this particular project because it not only provided a tool for patient satisfaction, but it also helped to rate patients' view of patient participation in care, which is really important when we're looking at SAMHSA's guidelines for the integration of mental health services into primary care, because a real key component into driving that integration is patient participation throughout the process. The improved health of the community was measured by the number of crisis calls. How many crisis calls were we able to handle proactively within this model of care? And the third, IHI triple aim, reduced cost of care, was measured by the potential cost savings. This was calculated based upon ER costs of care for mental health services. So we were able to pull diagnostic criteria for a mental health visit within the ER, target those costs. They were found to be well over $14,000 per visit to the local ER. So it was really pretty sizable cost. And then we were able to calculate a projected cost savings based upon the number of patients or crisis calls that were diverted from the ER and effectively handled through this model of care. Here's some of our results from the Collaborate tool. It's a very simple, easy to implement tool within the clinical environment. It literally involves 3 questions. How much effort was made to understand your health issue? Our target goal was 80% or greater. We had a great deal of respondents. We had over 79 respondents in the first question, and we had 80 to 81% per respondents within the next 2 questions. The next question, how much effort was made to listen to the things that matter most to you about your health issues as a patient? So again, we're really trying to target patient involvement in the care plan. And the next question was how much effort was made to include what matters most in choosing what to do next. So in other words, did the patient feel that they were a vital part of that plan and development? And fortunately, we greatly exceeded our goal of 80% or greater for these standards, and it was well over 95% in each of these categories. Our results in the next category, improving the health of the community overall. So again, taking that 30,000-foot view of the community and how can we really impact the community at large. We looked at the total number of crisis calls. In the first week alone, we were able to handle 16 crisis calls. So this represented 16 patients that were effectively diverted from the emergency room and handled within the outpatient setting appropriately. In the second week, we handled 15 calls, and in the third week, we handled 13 calls. So quite a few calls right out of the gate with the project. Now this is where it gets really fascinating. In our next IHI aim, the cost of care, we were able to strikingly reduce the cost of care. When we looked at the average cost of care for these patients that might have been handled for their mental health crisis or mental health diagnosis through the local emergency room, had they not participated in the integrated program of care, it amounted to $14,863 per visit, so very sizable. And each visit was on average involved a 2-day stay. So a lot of these patients were seen inpatient as well in the ED in order to help manage a lot of the things that we handled in the outpatient setting, including medication management, psychiatric intervention, and prompt counseling intervention. So our total cost savings amounted, we were able to see over 44 patients within the program through a 3-week period of time alone. Of those 44 patients, this represented a total cost savings of a little over $650,000. So it was a very sizable cost savings overall. We not only met, but we exceeded our goals as far as patient satisfaction. We're able to improve the health of the community by really handling a lot of these patients in the outpatient setting, both promptly and thoroughly. And we certainly were able to decrease the overall cost of care in our total cost savings over the 3-week period of time being roughly $650,000. I want to just reach out and give some special thanks to folks that were involved in this project. I could not have done that without their assistance and their support. Dr. Kimberly Couch, who helped supervise my DNP project, Dr. Heather Schlossler, who is also involved, the Access Healthcare team, extremely vital throughout the course of this project. They provided incredibly valuable type of care within the community and really are leading change in mental health integration into primary care, both nationally and internationally overall. And I also want to take a moment to just thank the folks at Institute for Healthcare Improvement for all of their support. And thank you so much for visiting today, and I really appreciate you listening to this presentation. If you have any questions or would like additional information regarding this study, please feel free to reach out to me via email, and I look forward to hearing from you. Hope you have a wonderful day.